Welcome, everybody, to tonight's program, Molecular Testing and the Implications for the Adjuvant Therapy in Early-Stage Non-Small Cell Lung Cancer. Dr. Charu Agarwal of University of Pennsylvania's Leslie Heisler Professor of Lung Cancer Excellence is our discussant tonight. And Charu, I'm going to go ahead and turn it over to you.
Sounds good. Thank you, Charles. Thank you for joining us tonight, and we're going to talk about molecular testing as well as implications for adjuvant therapy in early-stage lung cancer with an eye towards recent approvals in early-stage lung cancer and how we can incorporate molecular testing. So lung cancer is really the poster child of personalized therapy. We've made significant advances in the management of this cancer. Over the past 2 decades, you've seen that overall survival has significantly improved. Hi, Christian. It's gone from chemotherapy, median overall survival of about 8 months, to now KEYNOTE-24, 5-year overall survival with immunotherapy of 32%. Targeted therapy can also improve outcomes significantly, with alectinib improving 5-year overall survival to about 62%. So these are patients with metastatic disease really living longer. And as is usually the case, advances in therapy in the metastatic stage usually translate into the adjuvant and the neoadjuvant space. And this is what we are beginning to see and observe with the most recent data and the approvals. We know that in the adjuvant therapy or in the early stage therapy, resection is usually key and adjuvant therapy is administered, but it's important to recognize that adjuvant therapy, which is considered the gold standard, may not be that great, actually. Hazard ratio of DFS with adjuvant chemotherapy is 0.84. An overall survival improvement is rather modest at only 0.9, leading to a 4 to 5% overall improvement at 5 to 7 years, with really no significant improvement seen at 10 years following surgery. So what should we think about when we evaluate new drugs for adjuvant therapy? Of course, looking at their mechanism of action, safety, what is the potential for harm, magnitude of clinical benefit, cost, feasibility, and most importantly, is there a biomarker?
Charu, can you hear me?
In 2020, FDA approved osimertinib for the adjuvant therapy for EGFR mutant non-small cell lung cancer. These patients had to have EGFR sensitizing mutations, so exon 19 deletions or exon 21, as determined by an FDA approved test. You will see that there is really no stage limitations for this approval. It's stage agnostic as long as the resection has been performed. And it also doesn't include chemotherapy. So it's a very broad indication that osimertinib received. And then most recently, we saw data on the approval of atezolizumab for adjuvant treatment following resection and platinum-based chemotherapy in patients with stage 2 to 3A non-small cell lung cancer. So very stage-specific. They must have received chemotherapy. And they also are very specific that the tumors must have PD-L1 expression greater than equal to 1% as determined by an FDA-approved test. Again, I think this is important, and here's where the data comes from. It's the EMPOWER study, which I'll come to, but these guidelines and these approvals have made it to the NCCN guidelines, where you can see for stage 2 to 3, at the time of resection, the options are chemotherapy with either atezolizumab or osimertinib for those patients with EGFR mutant disease. So the data really comes from EMPOWER 010, which is a large randomized study that was conducted in completely resected stage 1B to 3 in non-small cell lung cancer per AJCC 7. These tumors had to be greater than equal to 4 centimeters following a lobectomy, pneumonectomy. They received 4 cycles of chemotherapy that had to be cisplatin-based and were randomized to receive either atezolizumab or best supportive care. And then these patients were placed on survival follow-up. The primary endpoint was disease-free survival in this pre-specified stage-selected, PD-L1 selected population. And then in a hierarchical fashion, DFS was tested in all randomized stage specific, and then DFS in the intent to treat population that was stage 1B to 3A. And then finally, overall survival. In the first version of these data, we saw an improvement in DFS for the primary population of interest. You can see the far left-hand Kaplan-Meier curve hazard ratio of 0.66 with a p-value that was significant over best supportive care. So atezolizumab for 1 year, leading to a median DFS that was not reached with a median follow-up of about close to 3 years. You can see that the other two curves don't really show a significant difference, even though the p-values are kind of significant, but the hazard ratios are 0.79 and 0.81. Based on this, the FDA approved it for the population that's on the far left. So PD-L1 positive stage 2 to 3A following chemotherapy. We know that the higher the PD-L1, the better the benefit. So if you look at the subgroup analyses, PD-L1 greater than equal to 50% seems to be the highest, the group that benefits the most with a hazard ratio of 0.43. As in all therapies, but more so in the curative setting, I think it's important to know what the overall survival advantage is. And here you can see that the overall survival advantage with atezolizumab in this population seems to be there at 0.71, although the curves are coming together at the 5 to 6 year mark. So I think longer follow-up is needed, and we need to know what happens. Again, as presented at this update at World Conference in Lung Cancer, the PD-L1 highest patients, TC greater than equal to 50%, hazard ratio was 0.43. So currently, survival data is still immature. So now we have adjuvant osimertinib, we have adjuvant atezolizumab, but we also have another option. So on the left, you can see if our patients don't have EGFR mutation, we can proceed with adjuvant atezolizumab for 1 year as based on the EMPOWER data. But we also have Checkmate 816, which I'll go over, which is neoadjuvant chemotherapy plus nivolumab surgery every 3 weeks for a total of 3 cycles, followed by surgery. And here is the trial. Again, surgically resectable stage 1B to 3A, 7th edition, good performance status. They excluded EGFR and ALK. So here's where the importance of molecular testing comes in. They have to be tested before they go for this regimen. They received either chemotherapy or chemo, which is platinum doublet, histology specific, plus nivolumab every 3 weeks for 3 cycles. And then they got staged and underwent surgery. Primary endpoint was PAT-CR by blinded review, as well as event-free survival. PAT-CR was hands down better in chemo-nivo. And this is what happened to the primary endpoint of event-free survival. Here you can see the event-free survival much better with a hazard ratio of 0.63 for those patients that received chemo plus nivo. And this is what led to the approval of this regimen in the neoadjuvant setting. Now, again, the population broadly included stage 1B to 3. And then when we break it down by stage, you can see majority of the patients on this trial, 2/3 of the patients on this trial were actually stage 3As, right? So on the right, you'll see about 228 patients that were enrolled with stage 3, and that's where the magnitude of difference is greatest. Median EFS almost doubled, 31.6 versus 15.7 with a hazard ratio of 0.54 on the right. And on the left, you'll see the difference is not that much. Again, these are subgroup analyses, exploratory, but also we find the same thread that the higher the PD-L1, the greater the benefit with chemo IO. And here you can see median EFS not reached with nivo plus chemo, hazard ratio of 0.24, significant separation of the curves for this population of patients with PD-L1 greater than 50. Very small numbers. I will say, again, these are inferences that we are making from analyses that are not powered, 38 patients only. But I think it's important to just see these data because they resonate with what we would think would be the case, and they are hypothesis testing. Overall survival also looks pretty good for the patients that received chemo-nivo. The overall survival data, it's immature. The median overall survival is not reached, but you can see p-values highly statistically significant with a hazard ratio of 0.57. So I think this is early data that's showing that if our patients achieve a PAT-CR, we may be able to extend that ability to cure these patients. So again, this is approved in the neoadjuvant setting, 3 cycles, limited duration immunotherapy, platinum doublet histology-specific chemotherapy. So why is molecular testing important? I think before we administer neoadjuvant chemoimmunotherapy, we must know, and then in the adjuvant setting, we don't want to inadvertently give anyone atezolizumab who may otherwise be a candidate for osimertinib. So it's important to test. At Penn, we have reflex pathways in place. So anyone who's signed out as a non-squamous non-small cell lung cancer undergoes molecular testing, obviating the need for a medical oncologist to place an order. However, this may not be the case at all institutions, and this may not extend to early stage resected non-small cell lung cancer. This testing often doesn't occur uniformly. There's also a 14-day rule regarding NGS testing on surgical specimens. And while medical oncologists may ensure completeness of testing in all stage 4 patients, not all patients with early stage lung cancer may be seen by medical oncology. So this is a proposed algorithm that we published on and we currently use at Penn. If you have a patient with a clinical stage 1 to 3 non-squamous non-small cell lung cancer, or somebody who doesn't have a stage that's unknown, if the biopsy is available, we usually undergo reflexive testing that includes PD-L1 as well as actionable alteration detection, and then the report is available. If there is no biopsy and if a tumor resection is planned here on the right, we usually undergo reflexive testing of the resection specimen, and we are actually incorporating some EMR-based nudges to help surgeons to remember when they see these patients at the first post-operative visit to actually order this test on the surgical specimen, so it's outside the 14-day window, and we're able to get the same reflexive testing. And then, of course, if the tumor is not resected, we can think about either another biopsy specimen or, think about how we may obtain more tissue, either it's an outside specimen, etc., for molecular testing. So with that, I'll stop here and happy to take questions before we get into cases.
A question, Samir Balouz here. In the neoadjuvant study, did they use only cisplatin or they used also carboplatin?
They used either cisplatin or carboplatin, and interestingly, there were higher PAT-CRs with carboplatin against small numbers, but we don't know why that's really the case. But I think in our experience, we tend to use more cisplatin in the early stage setting.
Okay, thanks.
I have a question about using adjuvant checkpoint inhibitors when you've done chemoimmunotherapy neoadjuvantly, because it was done in NADIM-2, that phase 2 trial. I'm always a bit leery whether I should be doing this or not.
Yeah, so NADIM-2 was specifically for stage 3, and they built in 6 months of adjuvant immunotherapy following the neoadjuvant chemoimmunotherapy. I think they did it regardless of EFS or not. Regardless of PAT-CR or not. And I don't know. I think if somebody achieves a PAT-CR, maybe the utility of adjuvant immunotherapy is not there. And again, I think vice versa. If you don't achieve a PAT-CR, is it because the tumor environment is just not susceptible to immunotherapy, and therefore giving more immunotherapy may not be worthwhile? So I don't know what the correct answer is. I think in the future we'll be even more discombobulated because all of the current trials that are reading out are combining sort of neoadjuvant and adjuvant immunotherapy without really an arm that gets neither. So I think we won't have an answer. So at this point in time, I'm not using adjuvant immunotherapy, at least not in those patients who will achieve a PAT-CR.
And have you ever used chemoimmunotherapy with a stage 1B that where the tumor is 4 centimeters or bigger?
We have not. Our practice has been to consider neoadjuvant chemoimmunotherapy in stage 3A, single station patients, single station nodal disease, or patients with high PD-L1, getting them tested for EGFR and ALK often takes a while to figure out who should really get it or not. In general, for these stage 1 tumors that are easy to resect, our surgeons sort of say, let's just take them to resection. And honestly, I think, if you were to look at this curve, stage 1B to 2 don't really benefit that much. And, if they're not really going to benefit, and I'm not going to offer them adjuvant immunotherapy, let's say in the adjuvant setting, I think surgery is the best way to go.
Because it's not significant, right? Crosses one confidence interval there.
Exactly.
Right?
But again, subset analyses. But yeah, your point is exactly well taken. It's not significant.
True. When's the next readout of this data going to become available?
So I think we're going to see something at AACR from Checkmate 816.
I'm curious to see
Sometime
what
in
these
April, I
curves
think.
do.
Yeah, so sometime in April. All right, I can go to cases if
Yeah, we had one case and one question.
Okay.
And is this Nicole's case?
Yeah, and I actually apologize. I didn't realize that the talk was limited to early stage lung cancer, and this is clearly a metastatic case.
But it was a good case. I liked it.
Yeah, we can talk about it.
So, I mean, kind of in a nutshell, this is an elderly lady who came to me quite frail, and she has primary metastatic lung cancer. The biggest problem are actually really her brain mets. There are numerous large, she also has some osseous metastases, right? We got the diagnosis from a CT-guided core biopsy from her left pelvic bone. And so we don't know that's adenocarcinoma. We did PL1 testing, was 0, but she has a MET exon 14 skipping mutation, right? So I started on capmatinib after talking to the radiation oncologist whether he'd feel comfortable with me not going for whole brain radiation. Stereotactic was not possible, it was way too many. I had a little problem with some itchiness and dermatitis, but then ever since then I've been struggling with her having lots of edema. The one problem that I have is from when I listen to the experts, they keep saying diuretics don't work that well and do lymphatic drainage. She's a little bit from farther away, and it's difficult for her to do any of that, and she hasn't done it. So she has not done any physical therapy / lymphatic drainage. But I had to really reduce her dose, and I'm at a really low dose right now. I think I'm giving her 150 milligrams PO daily now, if I'm not mistaken. I was giving her Zometa as well. So I was just wondering what I could do differently. I'm wondering whether I'm undertreating her, but she is responding very, very clearly. So the brain mets got a lot less numerous and smaller and everything. She's feeling better. When she was coming in a wheelchair to me in the beginning, she's now walking into the office and things like that.
Yeah, I think this edema with capmatinib is a huge problem. I often see this. I often see that Lasix doesn't help other than making them hypokalemic and hypotensive. So I've stopped using it. I usually will take them down to the lowest dose where I'm getting stable disease, and that's sometimes been 200 milligrams daily. You're already at 150 milligrams daily. 200 daily is the lowest dose I've gone to. I mean, there's a big difference in 400 BID to 200 daily in terms of just the dosing, but also in terms of the amount of edema we see. So that's what I've done. And I don't think there's another right answer for this. Unfortunately, these drugs are, not without toxicity.
Yeah. Thank you. I was just wondering, some weird myeloma drugs, you let them drink pickle juice and suddenly the symptoms get better. I was kind of hoping for like a secret trick or something.
Oh, wow. Which drug is that? Wow, that's interesting.
I think it's Velcade.
That's very interesting. I don't know if anyone else on the call has any tricks for capmatinib toxicity. No.
It's truly integrative medicine.
And then I think we had one more sort of a more broader philosophical
Yeah,
question.
this is a basic question that seems to keep coming in. And as I shared with you prior to the call, based on some survey work we done with previous call participants, that a majority of the physicians that are participating in these calls are now sort of routinely using the neoadjuvant approach with stage 3 patients, and probably half the stage 2 patients. And I'm just kind of curious, what you're doing at Penn and why.
Yeah, so I think it's very attractive to use the neoadjuvant chemoimmunotherapy approach, right? Because I think the pros are that it's limited duration, it's 3 cycles. You get them the chemotherapy and you're done with the immunotherapy portion. You don't have to give them a whole year of therapy. You give chemoimmunotherapy at the time that patients are feeling the best. They're not post-surgical. They're not missing part of their lung. So I think there's a lot to be said about the pros. But I think the disadvantages are that I'm not sure if I'm really offering a significant advantage in the form of neoadjuvant chemoimmunotherapy to a stage 1 patient where I may not even need to give them chemotherapy, or I may not even need to give them immunotherapy. And I may actually run the risk of missing an EGFR mutant patient or an ALK translocated patient, because really, surgeons are waiting on us, I guess not waiting to take them to the OR, right? So we need to find out their molecular status and get all this testing underway. And there's a real risk that a patient with EGFR mutant lung cancer may get chemoimmunotherapy, which may really jeopardize their chances of getting EGFR TKI down the line. So in general, what we are doing at Penn is that for these simple stage 1 and stage 2 peripheral non-small cell lung cancer patients with either no nodes or maybe 1 node or, radiographic stage 2s, they're going straight to surgery. For the stage 3s, we are making a case to present all of these patients at our multidisciplinary tumor board, and making a clear distinction. Are these definitive chemorads patients or are these surgical patients? So first branch is that. And if they're concurrent chemorads, let's not even talk about downstaging anyone or anything. Let's just go straight to concurrent chemoradiation followed by durva. For the rest of the patients that are potentially resectable, really the question is, can we take them to surgery right away? And if that's the answer, those are the patients that we would consider neoadjuvant chemoimmunotherapy in. And those are usually the patients that have single station N2 involvement, don't require pneumonectomy, etc. And those are the patients where we find that the benefit of neoadjuvant chemoimmunotherapy may be the highest. I will caution, though, I have 2 patients now who we considered for a neoadjuvant chemoimmunotherapy approach, both young patients. Turned out one patient had a PD-L1 level of 90%, and we were like ecstatic that this is the patient we want to do neoadjuvant chemoimmunotherapy, and we found out that patient had an ALK translocation. And the other patient actually, upon EBUS, even though radiographically we thought was only 1 node, but radiographically by EBUS ended up having microscopic multi-station N2 involvement. Therefore, we said, if this is multi-station N2 already to begin with, we're not going to take this patient to neoadjuvant chemo IO. So I think we're just selecting our cases really well to be able to get that benefit from neoadjuvant chemoimmunotherapy. We do still sometimes use trimodality therapy for patients such as this, where we would, for example, my patient who has microscopic N2 involvement, we did consider doing protons plus chemo, so chemo RT, stopping at 45 gray and taking that patient to surgery. So sort of our old, trimodality regimen where we would come in with concurrent chemoradiation followed by surgery. So we're still thinking of that and then incorporating adjuvant immunotherapy in the end. So that was a very long-winded answer, but basically trying to summarize that stage 3 patients are where we're using neoadjuvant.
I'm curious, is that consistent with other people's institutions?
That's not actually. We are seeing a lot of second opinions where patients come to us and say, hey, would you do neoadjuvant chemoimmunotherapy, or should I go for surgery? And then I look at their scan, it's a, it's a T2N0, and we discuss it at our tumor board, and everyone at our tumor board is like, no, why are you not going to surgery? So definitely we are seeing a lot of uptake of neoadjuvant chemoimmunotherapy, and I think that's because people think, oh, I can just get away with 3 cycles of immunotherapy and then I'm done.
I'd like to pose a question about something that Dr. Scolanta and I often discuss, so if you have someone with a PD-L1 expression that is 0, right, where you would not offer any atezolizumab after chemotherapy, would you consider this patient for chemoimmunotherapy, given I think there were like over 40% of patients actually did not have PD-L1 expression in that neoadjuvant trial? Or would
Yeah, so I think if the PD-L1 is 0, I would not offer adjuvant immunotherapy. You're absolutely right. And the
actually,
current
I'm more in
indication is
favor of, because there's so many people that were actually included with a 0% PD-L1 expression.
I know. So they were included. You mean on Empower 010?
No, in the neoadjuvant trial.
Oh, in the neoadjuvant trial. I'm sorry, I completely misunderstood your question. So in the neoadjuvant setting, I think since the immunotherapy has been combined with chemoimmunotherapy, I think I would probably still do it. Again, understanding that the benefit may be less. But if it's a really big tumor, if it's if it's truly stage 3A smoker, I would probably EGFR ALK negative. Think I would do it. I do have somewhere slides on differential activity based on PD-L1. The benefit is obviously smaller, but it's not 0.
And then along the same lines, if you have a stage 3B lung cancer and you're deciding on definitive chemoradiation, no surgery, and you have a PD-L1 0 expression, there is a sub-analysis retrospective of the Pacific trial that did not show any benefit. And I have just one patient like this, and I was really on the fence. Of course, this patient already has thyroiditis now. Had to happen, right? So
Yeah,
do you still offer it or not?
I offer it, recognizing that it's subgroup analyses, but also in Europe, it's not even approved for PD-L1 negative. So durvalumab is only limited to PD-L1 greater than equal to 1% in the Pacific setting in Europe. So the EMA did not approve it for PD-L1 negatives. But having said that, I don't usually withhold it from the PD-L1 negatives, given the fact that it was a retrospective subgroup analysis and the overall approval was broad and included everyone. But I actually don't give it to EGFR and ALK positive patients in that setting, even though the approval included them. So I do tend to create some boundaries even around approvals. But we are forced to, I guess, because there's no clear, straight answers.
Anybody else have any questions they would like to ask or cases? Okay, well, with that, we'll go ahead and thank everybody for taking some time out of their evening, and I wish everybody pleasant good night. And Sharu, thanks for a nice talk.
Thank you, everyone.
Thank you.
Thank you very much.